Okay, this is your Class 6 lecture, Care of Patients with Rheumatic Disorders. So we're going to talk about osteoarthritis, rheumatoid arthritis, gout, a little bit of lupus, a little bit of scleroderma. So you'll get a good picture of some of these different rheumatic diseases. We'll talk about treatments and nursing interventions. So arthritis actually consists of over 100 rheumatic disorders, and pain is usually the symptom that brings people in. They may also have swelling, stiffness, difficulty with range of motion, decreased range of motion. Okay, so now we're going to go into osteoarthritis is what we're going to start with. So that is a chronic, non-inflammatory progressive disorder that causes cartilage deterioration in the joints. Okay, so risk factors for this, it generally happens, this is generally called the wear and tear disease. Okay, so it's going to happen as people get older, and if they've been very active and athletic, it may come on at a younger age. This is also known as degenerative joint disease. It's the most common form of joint disease seen in the knee, hip, and spine, mostly in the weight-bearing joints. So it is a chronic, non-inflammatory, progressive disorder that causes deterioration of the cartilage. So non-inflammatory is a key here, because we're going to talk about rheumatoid arthritis, which is inflammatory. So inflammation is not characteristic, but it can occur later, like as it gets progressed, as it progresses. So increased use is going to cause problems. So if someone plays football or soccer, or they do things where they're pivoting and jumping, like basketball, and twisting, making quick stops, kneeling, stooping, so jobs where you have to do that kind of stuff too can lead to, it can be a risk factor. So nurses, you're at risk. And obesity is also a risk factor, and this is modifiable. Obesity is always a modifiable risk factor, so these people are going to be asked to lose weight. So there is no single cause that's been identified, but obesity is a risk factor, as well as reduced estrogen and other genetic things. But overuse is extreme overuse from athletics and things like that is a big risk factor as well. But that's why we say regular, moderate exercise decreases the risks. That just kind of keeps people in line and shape. So here is a picture of the pathophysiology. So looking at picture A here, this is a normal anatomy. So note we have the space here between the bone. It's maintained by this cartilage. Okay, the blue part is cartilage. So over time, the cartilage gets eroded. It starts splitting and then it chips off. The joint space then gets narrowed. See, because the cartilage is not forming a cushion like it did before. And then eventually we have loss of cartilage and the bone articulates with the bone. And this is where you'll always hear people say when they had their knee replaced that it was bone on bone. They could feel the bone on bone grating, and that's, I'm sure, a horrible feeling. So it jumped ahead without me telling it to. After it gets bone on bone, then we get these outgrowths of bone, these osteophytes. Okay, and that would be down here, these little bulges. Okay, and also the synovial sac is going to get inflamed and get bigger, and that is where inflammation comes from down the road. So as we said, it is classified as a non-inflammatory disease, but inflammation can occur when it gets really bad. So joint pain is going to be their predominant symptom. Like I said, that's what's going to bring them in, and it can range from mild discomfort to a real disability where they're unable to walk without an aid. Pain is going to get worse with joint use. So when it's early, they can just rest and it'll end up going away. But when it's later, the rest isn't going to help it, sleep isn't going to help it. In fact, they'll have trouble sleeping because the pain is getting in the way. Also, barometric pressure, as that goes down, the pain can increase. So you might hear people say that rain or humidity makes their knees hurt, and that is why. The pain becomes worse as barometric pressure decreases. Now, this can be unilateral or asymmetrical. So that is different from rheumatoid arthritis, which we'll get to in a little bit. So unilateral means it's only on one side. It could certainly be both sides as well, like somebody can have their left knee damaged and the right knee damaged also from an activity, but they are not related. Okay, so it is a unilateral disease. When we have overactivity, that leads to an increase in the intra-articular fluid, and that's known as effusion, and this is especially seen in the knees. And that leads to an increase in the stiffness. So this just shows some of the joints that are most affected. And again, with osteo, we generally think of that in the larger joints, the weight-bearing joints, so the spine, hips, and knees especially, but it can be anywhere also. So Heberden's and Bouchard's nodes, those are the bulges that you'll see when we have the picture of the joint there, the little outcroppings of the bone, and it can lead to a visible disfigurement. And that can cause the patient to be distressed. They can have an image problem. It doesn't really cause much loss of function, but it does kind of take up some of the joint space, and this occurs especially in fingers and the smaller joints. So some diagnostic studies. They can do different kinds of scans. So we can do a bone scan, CT, MRI, and these are to detect joint changes. So they would want to look at this early on, and then they can use that as a baseline and then compare it later, because it's more useful to monitor the progression or the response to therapy. Okay, so they take it now at the onset, and then you come back in 6 months, it's still not better, and they'll take another picture, and then they can compare them. So once it's progressed, in progressed osteoarthritis, it's going to detect the joint space narrowing. So they're going to see the bone-on-bone action. They're going to not see the cartilage in there. So they're going to see how badly it's progressed. Some lab tests. Whoops, keeps jumping ahead. Lab tests. ESR and CRP are usually normal. Those are non-specific tests anyway, but they can help rule out other things. They also might check the synovial fluid, and that will differentiate OA from RA by what they find in there. So how do we manage it? Well, we want them to rest when they need to. We want them to lose weight if they are overweight. That's going to be the first intervention that a doctor is going to recommend, is that they lose some weight and try to take the stress off of those joints. And in fact, some surgeons won't operate on a patient if they are obese. They want them to get down to a more manageable level before they go in there and try to fix the joints, because they know that it's not going to it's not going to hold up if they don't lose the weight. So they may also use heat. Heat's going to be more often used than ice, but ice is appropriate when we have acute inflammation. And then with medications, NSAIDs and COX-2 inhibitors, those will be used in conjunction with the non-pharmacologic, like the heat or ice and rest. And then eventually it may lead to reconstructive surgery or arthroplasty, so that's our total knees and our total hips that we see. Corticosteroids may also be used. There's a lot of issues with steroids, though, that we've probably already talked about and will continue to talk about. The immunosuppressing action of them, and the blood sugar raises. So resting and protecting, the patient has to understand the importance of this, as well as losing weight. If we do have to rest it and stabilize it, it should be maintained, the joint should be maintained in a normal functional position. Okay, so we don't want to put somebody into a brace or a splint that's going to have the joint be in an awkward position. And we don't want it to be immobilized for any more than a week. Heat and cold, again, I mentioned that. So heat's going to be more effective except when it's acute. They also may do paraffin wax baths. Like if it's in the hands, they can have them dip their hands in the wax. That feels really nice. Some other alternative therapies: acupuncture, yoga, massage, all those things. Glucosamine is something. It's a supplement that you can get. It's kind of controversial whether it helps or not. I took it myself for a while, and I felt like it wasn't. I felt like I was getting worse without any benefit of it, so I stopped. And that was after like a year of using it. So I gave it a chance. Then again, diet to reduce the weight. So drugs. So it's going to depend on the severity. First thing we'll always start out with is Tylenol, because that's, you know, over the counter and mild. Does have liver side effects, but in general, Tylenol is okay for everybody. And we'll give them the extra strength Tylenol, so that's 1,000 milligrams, and that should be given every 8 hours. Now you may see in your book or elsewhere that it could be every 6 hours, and the Tylenol debate I think we already talked about, but it used to say 4,000 a day was okay, and now they're going down to 3,000. So if you were to take 1,000 milligrams every 6 hours, that would put you at 4,000. And if you take 1,000 milligrams every 8 hours, you're only at 3,000. So we want to start really thinking in that direction and reducing the amount of Tylenol that people are taking. Okay, they may also use some topical agents. There's Aspercreme is an aspirin-based rub. It's a salicylate, and then capsaicin. This is a cream that is made from capsicum, which is derived from a pepper, hot pepper. It's very hot. It warms up the area that you put it on, and it kind of feels good. It can help. And then hyaluronic acid is another thing. When it gets to be moderate to severe, then we'll go up to NSAIDs like ibuprofen. They may put somebody on doxycycline, and that helps reduce the cartilage loss. So whenever we have someone taking these medications, any medications really, but especially Tylenol that's liver toxic, or those that are kidney toxic like NSAIDs, we want to make sure that people are drinking a lot of water. Okay, so at least 2,000 milliliters a day to help flush the system. Alright, here's a question. A patient with newly diagnosed OA would be initially encouraged to use which of the following medications in the management of the disease? So which one of those are we going to choose first? Just talked about it. Okay, right, Tylenol. And I did put this to be 3,000 a day because I want you to start thinking that way. Alright, next we're going to move on to gout. So gout is a defect related to purine metabolism. And purine is what some proteins break down into, and then our body has trouble flushing it out, and it builds up. Okay, so it ends up with uric acid crystals. So hyperuricemia means that uric acid is elevated in the blood. There are 4 phases of gout. You don't have to know the specifics of the 4 phases. You can read about them, but just get the general idea of what gout is. Okay, it's more common in men than women. In fact, it's about 90% in men. Its incidence is pretty rare, but it has been on the rise in the last decade or so. So we have either primary or secondary gout, and if it's primary, it's often inherited. So it can be an overproduction of uric acid or else under secretion by the kidneys. So we're either making too much or we're not getting rid of enough. So let's take a look at the diagram here, the spiral of gout. Okay, so the attack starts here, and we get these crystals that form. Then the white blood cells attack them because they're foreign, they shouldn't be there. The crystals pop the white blood cells, which release proteins. And remember, what caused the problem in the first place is proteins, or purine. So then these proteins that are out there, they call in more white blood cells, which causes inflammation and pain. Proteins break down into acids, so that's going to lower your pH, and that makes it possible for more crystals to form. And then we start the cycle again. So that's the spiral of gout. So it just kind of continues to get worse unless there's an intervention. Okay, so again, we're either making too much or we're having trouble getting rid of it. If it's secondary, it's going to be related to other diseases that lead to the same thing. It leads to you either making too much or not excreting enough, or both. And some diseases that cause that, DKA, diabetic ketoacidosis, severe diets, starvation diets, metabolic syndrome. There's others in the book you can take a look at. When it says severe diets and starvation, I don't know if you guys are old enough to remember, but there was a big diet craze about 15 years ago called the Atkins diet, where all you could eat was protein, no carbs. Like nobody was eating any carbs at all, and you have to have carbs to maintain brain function, and people were really getting they were losing weight, but they were damaging their body, and that has led to an increase in gout diagnoses because of all the proteins that they were eating. It breaks down, and then they have hyperuricemia. So the attacks that come on are related to a sudden increase or decrease of uric acid levels. Uric acid levels. So when it's acute, it usually occurs in one or more joints, and it's generally thought of as the big toe disease. So when someone has pain in their mid-metatarsal area or in their great toe, the first thing someone's going to think of is that it is gout. Okay, so that's an acute problem. If it is chronic, there's going to be multiple joints involved, and they're going to have what's called tophi, or tophi, and those are clusters of crystals. The serum uric acid levels, this is something that also is not real definitive or specific, but 6 milligrams per deciliter is the goal of therapy. Once they put people on meds, they want to keep it under 6. There are meds that we're going to talk about that you can see on page 1059. There's a chart about the meds, so let's get into that. So in an acute phase, we're going to go for NSAIDs and colchicine. So we want to manage these acute flare-ups, and then there's also going to be long-term management to prevent the flare-ups and also control the hyperuricemia. So the NSAIDs we're going to use are ibuprofen and indomethacin, and then also colchicine. And then if we're not responding to that, to the NSAIDs and colchicine, and those can be used in conjunction with each other, then they're going to go to corticosteroids. Okay, and what do we know about corticosteroids? A lot of things. Remember, keep those always in mind. Whenever you see corticosteroids, you want to think that the blood sugar's going up and the immune system's going down. And also, how do we stop them? We taper them off, right? So long-term management, we're going to give them a xanthine oxidase inhibitor, which is known as allopurinol. So whenever someone hears allopurinol, you think gout. That's a gout drug. It's the drug of choice for preventing attacks and tophi formation. And Xyloprim is another name for it, but you'll probably always just hear it as allopurinol. And then there's uricosuric agents like probenecid, which is also called Benamid. I've seen both of those names. And sulfenpyrazone, or Anturane. So Benamid controls the hyperuricemia. It dissolves the urate, and it causes dissolution from the joints, so the crystals break up and get detached from the joints, so that helps. Anturane is similar but more potent. It has some blood damaging properties, so we want to use that with caution. Okay, now so these two, dang it keeps slipping ahead. So the long-term management, the allopurinol helps prevent the attacks and the tophi formation, but it doesn't really fix the problem. The uricosuric agents do. Okay, so they correct the hyperuricemia and they dissolve that urate. Now we also want them to limit the use of alcohol. We got to have some diet changes. We're going to decrease the purines that we take in. So we're going to limit consumption of foods with purine, and just the easiest way to think of that is just limit protein from meats. So organ meats, meats is spelled wrong, shellfish, and what else? Well, beer and wine. We also want them to drink 2 liters of water per day again, and that's to flush things out. So not only flushing the drugs out that they're taking, but to help keep the blood more flushed and motile so that the crystals don't form and build up. And next is fibromyalgia. And this is something that's very non-specific. It's really hard to diagnose. It affects women more than men with a ratio of 8 to 1. And there are 18 points on the body that are tender, that are specific to fibromyalgia. Or when they find that a person is having trouble with those 18 areas, with 11 of those 18 areas, then they can consider it fibromyalgia. And those are seen on page 1059. So they are going to have sleep disturbances and mood disturbances. They have a burning pain, but they can't really nail it down. So you ask them, is it a muscle, is it a joint, is it the tissue? And they don't know. They can't really specify. And they may get upset and irritable about it. So our treatment for this, we want to help them increase their independence. We want to encourage them to keep their social obligations, work out, be active, help to increase the strength and the function that they have. And then medications that we're going to give them. NSAIDs is what we'll start with. And then tramadol, which is an opiate that has been shown to be effective with fibromyalgia. Now there's some off-label uses of some other drugs, and off-label means that that's not what they're prescribed for. Okay, and they may not even be approved for that, but it has been found to work, so doctors will prescribe it. So these are all antidepressants and anti-anxieties, except for Lyrica, which helps deal with neuropathy and restless leg syndrome. Cymbalta, Prozac, Paxil, among others that are in your book, those are all antidepressants, and they will help with the sleep disturbances, the mood disturbances, and it can, if sometimes the antidepressants can help with pain also. And then the nursing care that we talked about, just encourage them to stay up with life and stay active. And next is rheumatoid arthritis. It's really important that you differentiate between rheumatoid and osteo. And I'm going to make some points that are going to make that clear. And then next time we're in class, I'm going to draw a diagram that'll help kind of cement it. I wasn't able to put it into the PowerPoint. It was becoming too time-consuming and difficult. So this is the most common inflammatory arthritic disorder. And we said that osteo was the most common non-inflammatory. This affects females more than males at a ratio of either 2 to 1 or 3 to 1. They say it kind of varies. And it's an autoimmune reaction, mainly occurs in the synovium, so in the joint area. So it is a systemic autoimmune disease, and that's important to note too, that it is systemic. Okay, so it affects the synovial tissues, the joint areas, but it also has effects in other parts of the body that we'll get to. Now normally begins in small joints like the fingers, but it can later lead to larger ones. And with osteo we said it was kind of just the opposite, right? It starts in the larger weight-bearing joints and it can move to the smaller ones. Now RA is usually bilateral and symmetrical, and that's important to note too. And we said osteo is kind of a wear and tear, so it happens, it could just happen to one knee that you fell on a couple of times over the years and it got damaged. But rheumatoid is going to be bilateral and symmetrical, so it's going to affect both sides of the body at the same time and roughly in the same manner. Now, upon palpation, if we touch these people's bones, the joints rather, where it's bulging out, it's going to feel spongy or boggy, and there may be fluid in there that they may aspirate. So they're going to have joint pain, swelling, redness, and a decrease in function, and that's what's going to be most upsetting to them. It also does involve some extra articular symptoms, outside of the joint area. We'll talk about that in a little bit. So the cause of RA is unknown, and there's really no infectious agent that's been found. But this diagram kind of shows how it gets inflamed. Looks kind of ugly. So when it is involved only in the articular area, we're going to have pain, stiffness, limited range of motion, inflammation. And again, the symptoms occur symmetrically. That's important to note. Starting at the small joints, sometimes going to the larger ones. So here's some typical deformities. I've got a few other pictures within the PowerPoint that you can see, but it just looks like the fingers are going the wrong way. They get kind of nodular and crooked and painful looking. Here's a chart you can take a look at that just kind of encapsulates it. You can go back to that. So when they withdraw synovial fluid, they're going to find greater than 20,000, and it's going to be mostly neutrophils. Okay. The RF factor under laboratory findings. This is present in 70 to 80% of people, but it's not a definitive diagnosis again. And also the ESR and CRP are going to indicate that there's acute inflammation, but that again, they're going to be increased, but that again doesn't really serve as a diagnosis. That just means that there's inflammation somewhere in the body. So those are really non-specific labs. When they pull the synovial fluid, it's going to be straw-like, so kind of yellowish, and there'll be fibrin strands and high white blood cells. So some extra articular features, they may have fever, weight loss, fatigue, lymph node swelling, and then these are some things here that affect other parts of the body that you really wouldn't think of as having to do with, rheumatoid or the joints. So cataracts can develop. They may get skin ulcers that are like pressure ulcers. Vocal cords can be affected, and that's going to lead to hoarseness. Then they can have some cardiopulmonary effects, pleurisy, pleural effusion, pericarditis, and carpal tunnel syndrome in the wrists. Sjogren's syndrome, this is where we get dry. So there's a decreased salivation and decreased tear forming. They're going to complain of burning and itchy eyes. Felty syndrome is something else that occurs with when there's severe nodules. So inflammatory eye problems, lung problems, and blood problems. So what do we do? Our primary goals are going to be to decrease the inflammation and pain, help them preserve their joint function, and prevent or correct any joint deformity. And that's probably going to be kind of difficult because it's probably already happening, and that's probably what's bringing them in, unless it's detected very, very early. And then we're going to talk about the drugs in a minute. We want them to rest, protect the joints, tell them about hot and cold applications they can do, exercises they can do to help preserve the range of motion, and we also have to involve the family in these teachings. So these are some things you're going to assess for. And give them, again, tips to relieve their pain and fatigue, help them eat well, get sleep, increase their mobility, maintain their self-care. Now, if you have hands that look like that, do you think you're going to be able to do a whole lot of your own self-care? No, not when it gets to a certain point. So that's why we want to try to prevent them from getting as bad as this picture shows. We also want them to have an improved body image, not be ashamed or embarrassed of their hands, help them to cope. Okay, and then medications, when we do have to treat them with medications, we can talk about that. So first is going to be NSAIDs and salicylates. So those are going to have anti-inflammatory and pain relief properties, and that's what they need. Second generation NSAID is a COX-2 inhibitor. Those don't have GI side effects like bleeding, so those can be good for people that are prone to GI problems. However, these do not fix the problem. They treat the symptoms, which is very often the case in medicine, right? It treats the symptoms, but it doesn't fix the causing problem. So something that will help fix that is going to be disease-modifying anti-rheumatic drugs, or DMARDs. So DMARDs, one of them, a popular one, is methotrexate. That's the drug of choice, and it's fast-acting, so that's good. It doesn't have to take time for it to build up in the system. However, it does have a black box warning, so be aware of that. Take a look in the book and read up on all the warnings. It has several, and especially it's not to be given to pregnant women. It is teratogenic, so read up on methotrexate. Dang thing. We're going to see methotrexate again in some other classes. It's used for some other things as well. Then next, biologic agents. Some ones you may have heard of would be Enbrel, Remicade, Humira. Those are some common ones. You may have seen the commercials or heard about them somewhere. Now these are immunosuppressants. So what do we know about that? They're going to lead to infections. It reduces the immune system. So we got to watch out for that. And then also, oh, I skipped it, it was up there, corticosteroids, glucocorticosteroids. Those are going to be given in flare-ups to help decrease inflammation and pain, but also they can be used to bridge while we're waiting for a slower DMARD to work. And I said that methotrexate is a fast-acting DMARD, but there are others that are much slower. So in the meantime, we want to give them some glucocorticoids to help relieve the pain and swelling. And glucocorticoids, side effects, osteoporosis, diabetes, infection, all those things. So remember, always think of those side effects with corticosteroids, and we want to taper them off. And then lastly, antidepressants. You think they're going to be a little depressed if their hands are getting all gnarly and funky? Yeah, probably. They also may have some sleep disturbances because of the pain, so antidepressants are going to help with the sleep and the mood. Alright, question: which of the following nursing diagnoses is most likely to be a priority in the care of a patient with rheumatoid arthritis? Take a look, what do you think? Impaired physical mobility. Okay, people are going to have some degree of immobility. Like I said, with the hands being all gnarly, that's, it doesn't really affect your walking around, the hands, but it's going to affect your mobility in terms of being able to care for yourself. It also can can affect the feet or the knees, so that would lead to the type of impaired mobility that you normally think of. They're not necessarily prone to falls or isolation or anything like that. Another one that wasn't on the choices, but self-image would have been another diagnosis. Okay, heat and cold therapy. Ice, when it gets really bad, we don't want to have ice on for more than 10 or 15 minutes, and it's really important to teach people because they can leave it on there and the hand starts feeling numb, and then it feels kind of good because it's numb, and so they just leave it on because they like that feeling, and then next thing you know they got tissue damage. So make sure you stress that. And then with heat, moist heat is going to be best, and heat shouldn't be on for more than 20 minutes. And we also need to teach patients about that we don't want to have them go to bed with a heating pad, for example, nor do we want them to put on some kind of heat-producing cream like a Bengay or Tiger Balm or the capsaicin. We don't want them to use that and then use an external heat device like a heating pad or an electric blanket, because that's going to end up getting too hot, and that can cause some tissue damage as well. So heat can help relieve the stiffness, which will help them to take a more active part in their therapy, doing their exercises and stuff. So inadequate joint movement can cause some immobility problems and muscle weakness, right? If we don't use it, we're going to lose it. And so they're not going to want to be doing their exercises and moving around much when they're all swollen and painful, but that we need to understand and help them understand that that's just going to make things worse. And then also, over-aggressive exercise can result in increased pain. That makes sense, right? When you use your joints too much, you get tired. So we want to do gentle range of motion exercises daily to help keep them functional. Is the following statement true or false? A diet that is intended to manage a rheumatic disorder should prioritize simple carbohydrates and animal-based proteins. What do you think? That's false. You won't find too many diets that tell you to eat animal-based proteins, because we know that those are risk factors for so many other things. So we want their diet to come from whole grains, fresh fruits and vegetables, legumes, seeds, and nuts. So no simple sugars and animal-based proteins in moderation. Then next is lupus, and we're just going to touch very briefly on this. Lupus is another inflammatory autoimmune disease. Has variable presentation, so it can look very different from person to person. They also have remissions and exacerbations. What's the big cardinal sign of lupus that we can identify on someone's face? If you don't know, make sure that you read the chapter about it. So they have a lot of problems. So fatigue, many different pains. So it kind of sounds similar to fibromyalgia, because they're going to have muscle pains and joint pains, and they're going to be tired and, you know, just not feeling very good, kind of general malaise. The diagnosis is going to be made after taking a complete history and physical, and there'll be some diagnostic tests. They will be getting multiple medications for treatment, particularly corticosteroids. Then scleroderma is another problem here. This is kind of an interesting one. It often starts insidiously with Raynaud's phenomenon, and Raynaud's, it happens mostly in women to the fingers, and what happens is cold or stress can lead to vasospasms, and then that turns the fingers, they can go red and white and blue, and then they can eventually end up kind of getting crunchy and falling off after a while if it's not treated. So cold and stress brings it on. So often scleroderma results after Raynaud's has come on. Raynaud's can also occur with RA as well, so read up on that a little bit. So when they get scleroderma, the skin gets hard and firm. When I was younger, I knew a lady, Mrs. Kennedy, who had this in her arm, and she was telling me about it, and she let me touch it, and it felt like her arm was just so swollen, like when someone has really severe edema and the skin is very taut, but you could touch it and it didn't give at all. It was very hard, so it was like there was all this fluid or something underneath the skin, but it was hard. It wasn't squishy like fluid would be. So the skin gets dry, the sweat glands get suppressed, so we don't have sweat or oil coming out, so the skin is dry. The extremities is going to stiffen and lose mobility, and it spreads slowly. So for many years it could end up being in the hands or the feet, but then eventually it can spread. If it gets into the face is going to be immobile, kind of mask-like and expressionless, like a real housewife who's had too much Botox, but it also is very firm and rigid, so it's not a good thing. So the vascular injury and damage, that is the first thing, and that's what Raynaud's is. And then there are two different arms of the immune system, the innate and adaptive, and those both kick in, so it's autoimmune, innate and adaptive autoimmunity. And then we get the generalized interstitial and vascular fibrosis. Okay, and that's where just everything gets hard. And as it spreads throughout the body, although not visible, there can be some things inside that are very dangerous, like the left ventricle of the heart. It's going to lead to heart failure. If the esophagus gets affected, you're going to have trouble swallowing. If the lungs are involved, trouble breathing. So all of these things, it's not just on the outside, so all of these things can occur, and it can lead to death eventually. And there's a little joke for you. So we didn't spend a whole lot of time on fibromyalgia, lupus, and scleroderma, but you should read them. It's only a couple of pages each, so be familiar with those. And most of this chapter has been concentrated on osteoarthritis and rheumatoid arthritis, so I really want you to know about those and know the differences of them. When we get into ortho in the next class, we're going to start talking about joint replacements, and those are going to be results of which of those two kinds of arthritis. And a lot of our patients are going to be in for those joint replacements in clinical. So be aware of what's going on. Alright, now go and take the quiz.